physiologist, and I am the owner of my own business, Dizzy Heads & Co, as in comorbidities. I have been specialising in all of the things listed there, but since having my own child, so my little boy is now 3.5, and also connective tissue disorder, and the experience that I went through, I have a real passion in pregnancy and postpartum management with those living with invisible illnesses, a topic that I also presented at the EDS Society Global International Conference in August this year, which was held in Arizona. And I have also been living with my own invisible illnesses for the past 15 years. So pretty much hypermobility since I was a young person, but sub-elite athlete. But unfortunately, pericarditis took a big halt of my life. And unfortunately, just suffering my second bout of pericarditis as of last week, hence my nice little halter here that I'm wearing today. Didn't just put this on for today. So yeah, have my own long-term experience with these illnesses, and hence my passion and advocacy, and really grateful to the Australian POTS Foundation for asking me to present alongside Caelum today.
Yeah, it's been a fantastic honour to be asked to present at this webinar today. So thank you again to the Australian POTS Foundation. My name's Caelum Schild, and I'm a senior exercise physiologist as well, and partner at my own business, Lofty Health and Wellness. And quite similar to Jacqui, I do specialise in a lot of those various different invisible illnesses, including POTS and dysautonomia, and likewise live with my own invisible illnesses in terms of orthostatic intolerance and fatigue, which I've managed to live with and work with for the past sort of 10 years or so at least. So again, something that I'm incredibly passionate about, and want to make sure that we move forward in this area and help as many people living with these things as possible. So we'll head on to start the presentation today, just in terms of some learning outcomes. So hopefully after the session today, everybody can begin to identify the role of the autonomic nervous system within the body, gain a deeper understanding of the underlying mechanisms of dysautonomia and POTS, identify some of the triggers and the symptoms involved. And then I guess the key for today's session is really running through how to conduct an initial assessment and the depths that are required for that. And then also some of the factors that influence the function of our autonomic nervous system. So we'll start with what is the autonomic nervous system. Sometimes we can refer to this as being the forgotten about part of our nervous system, if you like. So in this overview here, you can see that we often refer to that neurological function and think of the central nervous system, so the brain and spinal cord. However, that autonomic nervous system is equally important in the function of our body. So really it runs all those background bodily functions, and these functions don't usually require that conscious thought or action. So things like breathing, digestion, heart rate, blood pressure, temperature regulation, and the list goes on. We'll touch on that in a bit more depth in a minute. So we've got three main components of our autonomic nervous system. The two main common ones that we often refer to are the parasympathetic and the sympathetic. So the parasympathetic nervous system mainly uses the neurotransmitter acetylcholine to transmit information to the end organ, having a calming effect on the body, while the sympathetic nervous system mainly uses the neurotransmitters epinephrine and norepinephrine to transmit information to the end organ, having more of an arousing effect on the body. So the next slide, we're going to just differentiate in this next little period the difference between dysautonomia and POTS. Before we start talking about the definition of POTS, It's important to note that the phrase postural orthostatic tachycardia refers to the quickening of heartbeats in response to a change in the position of the body, usually from a recumbent position to an upright position. The heart rate is expected to stabilise and remain within a normal range that's higher than that supine position for as long as the person maintains that upright stance without translational movement. When this process becomes dysfunctional, we refer to it as POTS. So from here, we've got a bit of a definition of what POTS is as it stands at the moment. So some important points about POTS, the POTS diagnosis include: it is a collection of symptoms. So orthostatic intolerance in itself is not necessarily a diagnosis, but it's a state of being that involves many symptoms, including things like dizziness and lightheadedness while standing. Perhaps the biggest issue with POTS diagnosis is when there is obvious hypertension, hence why the understanding of the criteria is important. So for example, if someone had tachycardia and hypertension, we would likely refer to this as orthostatic hypotension with postural tachycardia. And you can see that there in point number 2. So that's something that can quite often get missed. The heart rate increase must be sustained. So many people will have a transient increase in heart rate immediately on standing. That gets better after the first sort of 45 seconds or 1 minute. This likely relates to a variant of that initial orthostatic hypotension, and in itself isn't a manifestation of POTS. POTS has a strong female predominance, so 4 to 5 to 1, and primarily affects women of childbearing age. Time frame can be 3 or 6 months duration. It does depend in Australia as to where you go, as to which diagnostic length will be used. And it's important to note that even if someone doesn't meet the criteria for POTS, we as Allied Health will still treat them according to their symptoms. Ideally, we want to find out exactly what they've got, but it's something to note that even if they miss out on that change in heart rate by a few beats a minute, we still need to treat them according to their symptoms. A couple of other neurocardiovascular compensation strategies include orthostatic hypotension, which we've mentioned, so that's an uncompensated neurocardiovascular dysfunction, and vasovagal syncope. Although POTS and dysautonomia are often synonymous, they can also be separate, as you can see in the Venn diagram. So we'll move on to the next section where Jacqui's going to talk a bit more about dysautonomia.
Yes. So dysautonomia or autonomic dysfunction, so it's used as a term to describe like a collection of signs and symptoms, and hence why we refer to these conditions as a syndrome. So that is that it results from the autonomic nervous system not working properly. And this type of a diagram is something that I really like to show to patients, because they can often look at a diagram like this and go, yes, that's what I'm experiencing, or that's what I feel. And they can really relate to where, yes, they think, yes, I'm ticking all the boxes in that fight or flight diagram, but what we want to really look at is it's more so the absence of the parasympathetic nervous system not really working properly. And that's where with a lot of these patients, we will notice that there is a collective of symptoms of cardiac, gastrointestinal, neurological, pulmonary, and the list goes on and on and on from there. So we've all heard, most of us have probably heard a lot about the vagus nerve and how this is involved in these types of syndromes. So obviously the vagus nerve is the main part of the parasympathetic nervous system, and as Caelum alluded to earlier, that abnormality of the production and the activity of that acetylcholine will have an effect on how that part of the nervous system functions. So in some people, and where if people have heard about, we have the hyperadrenergic type of POTS, hypervolemic POTS and neuropathic POTS, but we often don't, we're moving away from people having particular types of POTS, but rather they will move through you know, a different state from hyperadrenergic to you know, just a standard dysfunction of the nervous system. So for some people that can be too much, some people that can be too little. But when looking at this diagram, when we look at the amount of gastrointestinal type problems that so many of our patients have, and so many of our patients that talk about, it feels like they have hypoglycemia, and you know, whether it's hypoglycemia or just the inability of the body to know, you know, when it's hungry, when it's full, what that energy metabolism is like. I mean, I guess it can feel kind of same but different, hence why a lot of eating strategies for this population are smaller, more frequent meals, and balances, and the differences between carbohydrates, protein and fat, which we've got a dietitian that's very experienced in this coming up for a presentation next year. So what we wanted to talk about here is obviously, you know, the triggers of dysautonomia, and there are so many. But one thing I guess I want to mention is about the AusPOTS registry, which you can read about on the Australian POTS Foundation website. I've put a link here in the presentation. So currently close to 500 participants currently enrolled. It may be more since when we've written this, but the AusPOTS registry seeks to collect and analyse medical information from those diagnosed with POTS, and that is going to really help us better understand some of the associated conditions that come with POTS, as well as how POTS affects people over time. Another part of the AusPOTS registry is obviously COVID-19, and Marie-Claire Seeley, who's with us today doing a PhD, is, you know, obviously looking into studying and exploring the hormonal, inflammatory and immune biomarkers of POTS and long COVID syndrome. So unfortunately, as much as we know that POTS has been around for so long, it hasn't been until COVID that POTS has really come to the forefront. So, you know, a benefit from those who have been suffering for such a long period of time. So as you can see here, there are lots of different categories of what triggers can be, but we've written a little bit of a list there. So the biggest ones have been infection and gradual onset. So as we talk about, there's it's almost like when we talk about the how we do the assessment of somebody with POTS or dysautonomia, it's this kind of wind up of you know, triggers on a spring, if we talk about, and then that spring's eventually going to pop. So you know, a lot of people we know is infection, but as we're talking about childbearing age, so onset of menses is a big one. So a lot of our young females, their first period, hormonal influences, social pressures, being at school, and then there's also pregnancy. So we have this obviously a big increase in blood volume, and then when that gets taken away after baby is born, depending on how much of a blood or fluid loss is happening with postpartum, then that can be a big trigger for POTS as well. I'm someone that has suffered from concussion and post-concussion syndrome, and that can be a really huge disruption on the autonomic nervous system and those types of symptoms as well. Surgery, obviously being an impact on the autonomic nervous system. Usually when we're going in for a surgery, we're made to fast, we're dehydrated, then we get hit with an anaesthetic involving vasodilation. and then depending on the type of surgery, whether we can rehydrate and things like that to compensate for those types of things. And often what we will see is if people have had multiple surgeries over a short period of time, and then the body obviously being really deconditioned with a lot of those vasodilatory type effects, can really affect somebody. But many other things there, as you can see. So as per the amazing book Disjointed and the presentation by Dr. Andrew Maxwell, love how he divides this up in terms of a top-down assault. So this is where our concussion, CCI, which is what we commonly see in people with hypermobility or Ehlers-Danlos society, same as Chiari malformation and some of these CSF leaks, full body assault, which is a lot of our autoimmune and neurotoxin type effects, and the bottom up assault being those end organs, so MCAS, leaky gut, affecting the autonomic nervous system. So often when we're seeing a patient, they will tick and talk about symptoms a mile long, which is affecting essentially every system they have in their body. So someone will often come to you with a long list of specialists because of the long list of symptoms that they have been experiencing over a long period of time, covering pretty much every organ system in their body. Excuse me. Many of these specialists, unfortunately, and to their credit, are obviously only going to stay within their field. And rather than linking all of the other symptoms and issues together, leaving so many of these patients really frustrated and confused, and with a handful of different strategies. And when we throw in fatigue and brain fog and everything else that's going on, they have so much difficulty trying to figure out the strategies from their gastroenterologist, their dietitian, their cardiologist, their immunologist, etc., etc. So this is where it can become really distressful for the patients. So the most notable affected organs in this autonomic dysfunction is the brain, and so many people are really distressed by the brain fog and the concentration difficulties, and that can be from momentary interruptions of delivery of oxygen and nutrients to the brain, so poor perfusion, dizziness, lightheadedness, the blackout vision, tunnel vision, migraines, headaches, etc. So and there's a lot of sensory involvement, so a lot of people would tend to experience a lot of what we say kind of chest up type symptoms, and then pain and fatigue and tachycardia from within their body, but we know that it goes much deeper than that. So I'm going to hand over to Caelum to discuss these next few slides.
So if we just have a little bit of a look at what's happening at a deeper level in regards to POTS, so it's a form of compensated neurocardiovascular dysfunction. And so with that, there are a bunch of different consequences that can result. So Jacqui just touched on there in regards to the brain fog and the tachy and palpitations. So I guess if we look at it, that there are a couple of different forces that generate that orthostatic cardiovascular stress. So we've got gravity, as you can see there on the left-hand side with the yellow arrow, and also skeletal muscle contraction. So in terms of the schematic on the left, it's if we imagine that as being a vascular tank, and we've got a standing adult human, normal preload would tend to mean that we've got a full right and left ventricular filling, and this provides a normal stroke volume, which then leads itself to having a normal heart rate. A normal stroke volume produces a normal cardiac output. However, when we see an inadequate central pull of blood, this might be because of either, say, low venous volume, or that volume displaced downward by gravity. That can lead to an inadequate preload, such as that the stroke volume falls. So when that stroke volume falls, the normal compensatory mechanisms will increase heart rate to maintain that cardiac output as best as possible. further added to that, when we get that blood pooling, as you can see in the schematic, it's got a little image of the kidney. So when we get that blood pooling occur as an effect of dysautonomia of heads, the kidneys essentially see too much blood volume from their perspective. So then they activate the mechanisms to excrete what they interpret as excessive fluid and increase the production of urine. This results in that sort of extra loss of blood volume and its electrolytes. So if we click onto the next slide, we've got like a nice schematic here of a vascular tank. So people with EDS and POTS, but without a lot of that, they can tend to have symptoms of the POTS, but without a lot of that dysautonomic type symptoms. So that venous wall will have about 30 times more compliance than the arterial wall. So although we get that autonomic dysfunction, which is generally considered to be a dysfunction of the parasympathetic nervous system, like Jacqui mentioned before, when that parasympathetic nervous system is not doing its job, the sympathetic nervous system naturally tries to sort of attempt to compensate for that. And this can lead to the sympathetic overdrive. So it's sort of that third stage, if you like, which can mean that we see an increase in the amount of adrenaline in the body at any particular time, and trying to fix that inadequate cardiac output. So generally we'll see this in people where if they experience more adrenaline, they might experience more things like palpitations or that sensation of anxiety, and basically a general widespread worsening of symptoms. So for this reason, I guess we can sort of use the term preload failure for POTS. So in terms of dysautonomia, we can see quite a wide range of presentations. So for some people, they may appear to have no contributing factors and then experience an insult on the body. So for example, it might be something like a COVID-19 infection and then be diagnosed with POTS afterwards. Likewise, as Jacqui mentioned before, we might see people who experience a lifetime of unexplained symptoms, which then eventually leads to a diagnosis of dysautonomia or POTS after many years of declining function. And in the management of phase 3 and 4, we should aim to pay attention to the 5 points of management, but we'll plan to cover those in more detail in future webinars. So for an in-depth understanding, so that's only the quick summary. As Jacqui mentioned before, Dr. Andrew Maxwell, his presentation at the 2022 POTS conference was fantastic. So I definitely encourage you to have a look at that once it's available next year. So I'll pass back to Jacqui again.
Great. So this is something that, again, Andrew Maxwell spoke about, and I guess the first time I'd really heard of this pentad super syndrome, but definitely kind of explains a lot of the presentation in my career that I have seen with a lot of my POTS patients. There's only been a very small handful that, if we were to refer back to, that Venn diagram that Caelum talked about earlier, is that there is a small population that sit outside that dysautonomia circle that are just purely POTS without a lot of the dysautonomic type symptoms. So yeah, a lot of what we will see is that there is some type of hypermobility, heads, or it could be any other one of the 13 types of hypermobile or connective tissue disorders, which then contributes to, so when we have collagen dysfunction, a lot of the time what happens is that a mast cell's role is to come in and protect and repair dysfunctional collagen or tissue. So hence where we can get that when we've got connective tissue disorders and dysfunctional collagen, then we've got mast cell dysfunction, whether that is autoimmune related or particularly connective tissue related. Then if we think about the gastrointestinal system, and that is again, all connective tissue, we don't have the the contractility and that peristalsis to help move things along. We get that, gastroparesis, delayed gastric emptying, slow transit constipation, etc., and then all of those dysautonomia type symptoms. So hence why when we're going to talk about the assessment very soon, it's really important how we start to dive in and ask questions about all of these different areas. Now, the next slide I'm going to show is, I'm not going to go through it all, but this just demonstrates how from these, 5 bubbles that I've just spoken about, how big it can get from there. And in my clinical experience, that this is still not something that gets picked up very well, and that is a national and international problem, and hence why we're here today spreading the word more and bigger through many of these associations and foundations, so that we can educate anyone and everyone to be able to look for these extra things. And even though I'm not going to say only allied health professionals, but this is where an important part of our role is, when we are specializing and really knowledgeable about these conditions and these syndromes, that we're not afraid to communicate with specialists and doctors around, well, this is what I know and this is what I'm seeing, and A plus B equals C, etc., etc. So we want to be able to be talking about, if there's a particular disease entity found, it can be predicted that there is an underlying syndrome present, and that's where we can help the big team that is often involved to come together to help an individual. So yeah, what is POTS? I guess we've talked quite a lot about it, but I guess this is the most shocking thing, and in my own personal experience as well, is that the average time until diagnosis is around about anywhere from 4 to 6 years. Patients have often seen anywhere from 7 to 10 physicians before receiving the correct diagnosis. Wait times, we know, to see a POT specialist can be anywhere from 6 to 36 months, and so many patients are misdiagnosed. And for any of you that are sitting here who experience these conditions yourself, or are currently treating these patients, how many of them have said, it's just anxiety, or you're just stressed, here's an antidepressant, see a psychologist, etc. And that gaslighting is so damaging to so many of our patients, and that's why we're so passionate about spreading the word, because nobody should really have to go through that when there is some real true signs and symptoms around these conditions. So what we're going to jump straight into now is how we conduct the thorough initial assessment. I think is that main point we wanted to put across today, and it's about how events in somebody's life have contributed to that loading of the spring. So first off, in my patient details form, I really make sure that I am covering, I've completed my rainbow training. So the community that is often, within these populations of hypermobility, EDS, POTS, etc., is, really asking, what somebody's pronouns are, what their preferred name is, and the gender that they identify with. And what, just from clinical experience as well, is that even though somebody's legal name may be, something, but their preferred name is something different because of the gender that they have identified with. So we always want to ask those questions and be very respectful in that way, because that just builds rapport right from the start, that you have asked those questions right from the beginning. From there, in terms of symptoms, so I could write a symptom list significantly long. But what we want to do is, there's a wide range of presentations observed. So some people might only tick 1 or 2 boxes, and others may tick every box. And some patients will have a bit of a giggle of going, oh, I ticked every box. And we go, well, that just leads us to more of the pathway that they have been through. So we want to be able to dive into in a lot more detail of, not just seeing that they've ticked a box. So for example, headaches, which we are going to have a whole webinar dedicated to headaches in dysautonomia in 2023. But we want to know, the location that they experience the headaches. Does it get better or worse with standing versus lying? So we're looking for clues of CCI, Chiari, cerebrospinal fluid leaks, TMJ, etc. Have they ever had, a lumbar puncture, whether it was a suspected meningitis? Did they have a spinal with some pregnancy? If they had to have a cesarean section, have they had a concussion? So any of that kind of top up assault, we're really looking for in terms of those headaches. Sore throats, tender glands, do they wake with them? Do they notice it when they're stressed? Do they get it at the end of the day? Issues with periods, so at what time of their cycle? So do they feel that they have a real dip with their fatigue, dizziness, lightheadedness in their luteal phase versus their premenstrual phase? And we can really start to look at the influence of hormones. The physical fatigue, we know that there is a baseline of physical fatigue, and is that with exercise? Is it shopping, housework, socializing, sitting, standing? Concentration, is it with working, socializing? So even though socializing, so many people enjoy socializing and they don't realize how much of a drainer that is on their energy. So that's one to really highlight with many patients. Is it, talking on the phone? Does that drain their energy? Is it watching TV or trying to read a book? With their memory, is it always really bad, or is it worse as the day goes on? Dizziness, when does that occur? Is that upon standing, sitting still, lying down, turning their head, standing still? So this is where what I've seen in many patients is, are we dealing with a pure, POTS dysautonomia presentation, or is it vestibular involvement as well, or something what we call triple PD? So it's a persistent postural dizziness. Fainting, again, we're trying to really tease out when does that occur. So for some people, they can be fainters their whole entire life, and their thing is, oh yeah, I always hated assembly, standing there still, and when it was really hot in the summertime, and then they'd faint. And the sensitivity and the sensory overload. So is that lights, noise, temperature? Is that hot weather? Is it cold weather? Is it both? And then allergies, we tend to talk a little bit about in the next few slides as well. But I'll hand over to Caelum for the next few.
Yeah, so we'll chat a bit about pain now. So for the pain section, I guess the key thing that I like to get a bit of a feel for is trying to get some understanding as to whether their pain might be related to dysautonomia, if it's someone with maybe all 5 of those different syndromes that Jacqui was mentioning about before, or whether it may be related to more hypermobility or mast cell issues or some small nerve fibre dysfunction, or even from an old or a new musculoskeletal injury. So what we tend to like to delve into a bit more is what's actually painful for the person, and where their pain is. So is it a specific site, or is it something that moves around the body? So more of a roaming pain. the type of pain that they're experiencing as well. So for some people, they might describe it as more of an intense stabbing pain. Perhaps it's an increased response to what should be a painful stimuli, let's say like a thorn or something like that. Or is it something more so where it's a painful response to a normally innocuous stimuli? So if somebody touches them, do they get quite a painful arm, for instance? And that's something I guess commonly will get brought up, particularly for somebody with more of that dysautonomia side of things, where they're already living a lot of their life in a fight-flight state. And quite commonly people will say, oh, if somebody rushes past me or brushes past me, I'll have to rub my arm to kind of get rid of that pain that they experience. So the numbness, tingling, pins and needles, or is it an ache all over? It's also really good to give us a bit of an idea as to whether that pain is constant or fluctuating, and particularly in terms of time of day and alongside certain activities or daily tasks as well. So one particular trigger for dysautonomia might be if somebody is just sitting sort of stationary, for instance, with their feet down, they might experience quite sore feet, but then they elevate their feet on a chair or something like that, and that pain might relieve reasonably quickly. Do they experience that pain at rest or activity movement? What sorts of things aggravate and what sorts of things can help to ease that pain? Their injury history, and to get a gauge of what their pain levels are at best, worst, and on average. Oftentimes, though, in this population group, we do see people's tolerance to pain is quite good. So I usually like to get a gauge as to what their coping level of pain. So ask them, if you want to use a standard VAS scale from 0 to 10, what their pain might be, but then also how well they cope with a pain at a particular time too. And then on the right-hand side here, we can see a nice little way for people who might be neurodivergent or paediatric population, or for people that are having trouble describing pain, to be able to colour or draw or use whatever language is best for them to be able to identify their pain. So on the next slide, we've got a bit more on medical history. So in someone's medical history, we're looking for things that have loaded that spring, and hints towards that hypermobility or EDS or autoimmune issues. Perhaps some eating issues can be seen in eating disorders or common GI issues of POTS. And unfortunately, and it's a pretty common thing that I see, is that too many patients go through eating disorder accusations. So their GI pain and issues are quite misunderstood. So recently I had a patient who was admitted to hospital in an eating disorder clinic, placed on bed rest. And even though both this patient and the parents identified no eating disorder whatsoever, and the hospital just plainly didn't believe them, so they made this person go to hospital and be on bed rest for a couple of weeks so they could be monitored. And out of that, it's now brought this particular person a significant amount of medical trauma following that incorrect sort of diagnosis or disbelief or gaslighting. And then on the right-hand side, looking at medications are important, and we've got a slide in a second on that, so I won't touch on that too much, but getting a bit of a guide of diet and fluid intake as well. So sensitivity to alcohol can be an interesting one, potential that it can be an indicator of mast cell dysfunction or vasodilatory response for dysautonomia. And knowing someone's water intake too. So common medications. I guess one of the key things here, particularly from an exercise physiology perspective and physio, and if we're looking at getting people moving a little bit more eventually, it's really important to make sure they've got adequate blood volume when introducing that physical activity, movement or activity or exercise. So we need to really sort of work out what that ideal amount of salt supplementation might be for somebody, because if we start to introduce a great level of physical activity and they simply don't have that blood volume there. So thinking back to that schematic on cardiac output before, if it's simply not there, if we simply don't have that venous return coming back to the heart, we can't expect them to begin exerting themselves. Even in a reclined position, it can make it much more difficult. Essentially, the way that I like to think of it is that for medications, for each medication, we have a lifestyle equivalent. So salt and fluid can be quite similar to Florinef. Salt and fluid and compression can also improve heart rate. So they can be quite similar to something like an ivabradine or a beta blocker. Mitogen, we've got both trying to, one of the aims is to improve muscular strength in the lower limbs, but also compression garments can be very helpful there. And so that's where I guess if we look at that from an allied health side of things, although we need to have an awareness of medications, also being aware of the role that they play is important as well. So on the next slide, we've got what I guess a lot of people would see as a bit of a sensitive topic, but we're not approaching the drugs and smoking in a negative manner, but it's really just a way to give us a bit more of an understanding of how our patients might want to be able to help themselves switch off and relax. It's quite a common thing and a common theme that we see where people with POTS will struggle to switch off, whether it be physically or cognitively. Mm. And likewise with caffeine as well. So is it something that they enjoy or use to give them energy? And I think if we break it into a couple of parts, there are some positive effects of caffeine in certain amounts. So the vasoconstriction can help that venous return, but there can also be some negative effects. So as a stimulant, it can create more of an issue if it overly stimulates and provokes an already sympathetic nervous system, but it's also got a diuretic effect too, so being mindful of that. And the next webinar is going to be entirely dedicated to dietary considerations for POTS, so we'll have some details about that later on, but gaining even a basic understanding of some of the dietary habits can be really helpful for us as people who aren't dietitians, but still allied health, to identify if people have adopted a certain dietary pattern as a result of their POTS, likely due to feeling better when they eliminate or induce certain foods. So that's something that's certainly worth discussing in that initial assessment. So I'm going to hand back to Jacqui now.
Yep. And just adding to the dietary side of things, there's some really quick and easy I guess more postural maneuvers that we talk about. So eating with feet elevated, for example, can make a huge difference to these patients, because what we're doing in that instance is, you know, rather than having all of the blood pooling in their lower limbs, is if their feet are elevated whilst they're eating, then they've got a sufficient amount of blood flow to the gut for digestion. And I always talk to my patients about, well, you know, as much as we're all, you know, when I was growing up, you eat dinner at the table, but if you've got a recliner, it's a nice easy thing because you can eat feet elevated and then just slightly, very slightly recline, just to allow digestion to happen. So we don't really want people to be kind of eating on the move and, you know, eat standing up and all of those sorts of things. So very easy and quick strategies that we can give as allied health while somebody might be waiting to see a dietitian. But in terms of sleep, so a lot of this population have issues with sleep, and that can be for an array of reasons. The busy mind being a number one thing. You know, I can probably confidently say that 98% of my patients are perfectionists, high achievers, thinkers, inability to switch off. So they've been pretty poor sleepers their entire life. They think of the most amazing things to say and do and write, and that thing that they have to do for work the next day as soon as their head hits the pillow. But what I'm often looking for around asleep is how long does it take for them to fall asleep. So if somebody falls asleep generally with under 5 minutes, and this is also, you know, if they answer yes and you want to ask them, well, have they always been like that, then we're getting some hints towards narcolepsy. So obviously that has been a condition that is also around about being linked with hypermobility, EDS, and therefore POTS. And some questions around that as well as we'd be looking at, you know, if you're in a dark room in the middle of the day, would you fall asleep straight away? Or if you sat on the couch and you were really still, would you fall asleep straight away? And people will be very confidently be able to say yes or no to that. Do they wake during the night? How many times? What for? Is that for the toilet, for rolling over, for pain, whatever it might be? How long does it take them to fall back asleep? If they are napping, you know, do they feel better, worse, or same? So that's a really interesting question to ask, because, you know, if they're feeling worse or the same, then we kind of go, well, why are we doing it? Because it can have an impact on their nighttime sleep, which then just has that vicious cycle going on there. So sleep can be a really good thing. And with my assessment form, which often you can't see on here, but if somebody was to answer yes, then there's other drop down boxes that happen on these assessment forms. Now, this, I should also say that this assessment form for myself, and I'm pretty sure Caelum, yours itself is, do the same, is that we send this entire assessment form to our patients before we see them, because we want to get their opinion and all of their answers before we see them, because then we're not spending, you know, a really significant period of time of going through their history. We've got all of that, and then we're only filling in the gaps from then on, and can start to make some plans and give them their pathway from there. So we obviously want to know, you know, getting them to tell their story, and I want to know everything from birth, pretty much. So, you know, when I talk about from birth, were they a preemie baby? Were they breech? Did they have any illnesses or issues? Were they sick with a lot of infections, tonsillitis, bronchitis, ear infections? Did they meet milestones, or were they a bit slower, which is indicative of some of the connective tissue or global developmental delay or DCD? Did they have a lot of injuries, and was that because they played a lot of sport, or were they generally clumsy? At what age did they get their first period? Did they have any particular issues? You know, performance overall at school, sports, art, music. Were they a high performer, perfectionist? What was their social life like? Introvert versus extrovert. A lot of our patients tend to be introverts, and particular stresses throughout their schooling life. Family medical history is obviously really important, because we want to look at, you know, how long and what other standout features have been going on. Living arrangements, we want to know, you know, do they have support there in terms of somebody being with them at home? Are they supportive and understanding? Do they help out, or are there any other external services that they have? Relationship status, again, developing and building rapport. We want to know the ins and outs of what's going on. You know, are they supportive and understanding? And what I often like to do, and I always offer to my patients, is that bringing, you know, the friend, partner, parents, whoever into the sessions, so that I can be the one explaining what's going on, can often be a lot easier for the people involved in my patient's life, rather than them trying to tell the story. That, you know, brain fog can often be a bit of a hindrance in terms of that. In terms of if patients have children, you know, names and ages, so that you can always refer to them by, you know, their name, and obviously wanting to know if they've got any other medical and health conditions as well. And again, as I mentioned earlier, social connection. This is such a lonely journey for so many people. I know myself, I lost a lot of friends and family who never really understood, still don't. And therefore it can be really hard to know, who to talk to and who to rely on and who can really be there for you. So really important to know what somebody's support network is, and we can help connect people to others who are just like them, which is something I really love to do. And I'll hand over to Caelum to present the next few slides.
Yeah, that one definitely flows on nicely to the mental health side of things as well, because when you go through such a change in health and potentially losing friends and support structures, then we can potentially see greater impacts on mental health. And I guess I like to categorise the mental health side of things into a couple of different categories. So sometimes we do see people where it might be something underlying primarily, but then oftentimes in people it might be something more secondary to having the dysautonomia, and all those changes that we've sort of discussed a little bit more previously. So this mental health side of things in terms of the initial assessment can provide a lot of different insights. So not only those contributing factors that might sort of lead to loading that spring, and I guess a few examples of things like PTSD, it might be grief due to losing a loved one, sexual abuse and domestic violence. So these things, I guess, where Jacqui's mentioned previously, giving us some idea as to what's sort of occurred right from birth. And often if that sexual abuse has occurred as a child, it can have a pretty substantial impact on their autonomic nervous system. But also then, like we said, secondary to dysautonomia, is it something where they're having such a great impact on their what they used to do, and they're almost grieving the loss of themselves as well. So I guess from that side of things, if we're noting that many people with dysautonomia too have been misdiagnosed with anxiety when presenting to health professionals, so they might be a bit reluctant to discuss these things. So that's why I guess approaching it a little bit more softly and mentioning if it's comfortable for them to mention, it's certainly helpful for us, but oftentimes it's an area that's of great frustration simply because they've been misdiagnosed with anxiety in the past. One large study recently actually found that 77% of POTS patients were initially told by a physician that their symptoms were likely due to psychiatric or psychological problems. So when after that POTS diagnosis, they found that only 37% continued to have that diagnosis. So a significant reduction, 40% removed that reduction. So it's likely though, if we're using quick and sort of easy depression questionnaires, that some of those somatic symptoms of chronic invisible illness, things like appetite and weight change and sleep disturbances and fatigue, might actually inflate their depression scores. With this recent study, they assessed people with invisible illness, and they noted that one of the best depression scales to use was the Centre for Epidemiologic Studies Depression Scale Revised. It's got only 25% of the questions were related back to somatic symptoms, so it's less likely, even though it's far from perfect, to overinflate the somatic symptoms that we see with POTS. So on to the next slide. Relaxation is a big one, because obviously we will often talk about people's movement and how they're expending energy, but we also want to get a bit of an idea as well as to what sorts of things they go to for relaxation, and if they can still perform any of these now in their current state. So oftentimes if they aren't able to perform those relaxation or leisure activities, if they were quite active activities, it can sometimes lead to that secondary mental health issue if they can't do those tasks. So back to the grief side of things that we were talking about before. Jacqui mentioned previously as well around people struggling to switch off. So I'll definitely put my hand up as one of those people for sure. That substantial sympathetic overdrive can make it a lot more difficult for people to switch off, and they're the sorts of people that always feel like they need to be doing something, but oftentimes, whether it be, and this is where we'll touch on in a little bit more detail in future webinars around, okay, we might be wanting to pace doing something physical, but then follow that by something cognitive, so it still allows the body to kind of rest, even though we're doing something that might be a little bit more active. As Jacqui mentioned before as well, often many people with POTS are quite high achieving, so either athletically or academically. So in terms of work or school, they tend to find that they want to try and push themselves even when they may not feel up to it. So what often I find is a really good measure and really important measure, particularly in school-aged adolescents and children, is how many days of school they miss. And it could be with work as well, but how many of the days of school are they actually missing? And that's a fantastic objective measure, probably better than a lot of objective measurements that we've got for POTS, because it's such a functional measure, particularly in people who might be quite academically driven. And it's quite basic, but incredibly important in terms of their life and coping with POTS. And then we move on to things around capacity for daily living activities. So what they can complete, what they're limited with, what they're unable to complete, and if they've found any modifications. So examples of these might be showering or washing hair, and something that I always discuss with my patients around this is the potential vasodilatory impact that warm shower or bath might have upon them. So, and in some people, it can potentially lead to pre-syncope or syncope events, whether they use a shower chair, whether they shower towards the end of the day. For some people, that can be of assistance because they're lying down then during the night, but then for others, it might be something that increases their symptoms and they can't get to sleep. So it definitely depends on the individual. Getting some concept as to how they're going with things like dressing and feeding and cooking and cleaning and driving and socialising as well. One thing, and we'll touch on this further in future webinars, is those ADLs for some people with POTS can be a form of exercise in themselves. So essentially, if you think of what the definition of exercise is, which is any form of movement that increases breathing or heart rate, for people who may have gone several years before diagnosis, they might end up finding that ADL is an exercise for them. So I'll pass over to Jacqui for the next slides.
We will be doing another webinar solely on exercise and movement, because there's many different factors that go into exercise and movement for this population, particularly if it is accompanied by fatigue, which majority of the times it is. I think I've only ever seen 2 POTS patients in my career that don't have associated fatigue, and exercise was just what they can set off doing fairly well within some boundaries. But, what we're looking at here is, well, obviously what they were doing before their illness, how many times a week, duration, etc. And but what I'm really trying to pull from patients here is, well, how do they feel about movement and exercise? Are they really gung-ho and want to get going? So this can be, people rock up to their initial assessment and we go through this thorough assessment going, oh, we haven't done any exercise yet. And it's like, yeah, but as I explained to patients, I'd be doing them a disservice if I was just to give them exercise straight away without understanding all of the parameters of their life, hence an activity diary and looking at how they pace their day, what's involved in their life, which we'll talk about in other webinars. Are they trialing but failing in terms of doing boom and bust and having, you know, every second day they're in bed because of what they've done exercise-wise, but they exercise because that helps them switch off, or are they fear avoidant? So this is where you know, I very rarely will ever give anybody exercise, generally within maybe the first 3 or 4 sessions that I see them. So until I am confident that they are pacing and they understand pacing, and we've looked at gathering data on heart rate variability, etc., I will not be implementing exercise for them. And we're going to, in the presentations that we've got coming up, we're going to be talking about the differences between those who are bedbound with these types of conditions versus those who are at a moderate level. Really interesting is we want to be able to see what past treatments that people have tried, and whether they found that to be positive, negative, or neutral, so their own opinion, and what their current treatments are, and whether that is actually, you know, are they noticing much difference? Because we know how expensive treatment can be, and if somebody is seeing somebody that they're not actually getting real benefits from, then we ask those questions of, well, why are we seeing them, and want to be directing them in the best place possible. And then in terms of their goals, and I always come back to in every session what this person's goals are. So no matter what I'm talking about in terms of pacing, sleep, triggers, setback planning, etc., it's coming back to their goals, because this is about them, it's not about me. And I want to make sure that, you know, they know that I've listened to them, I've heard them, and it is all about them and what they're achieving. And it's a really good question of, you know, well, have I missed anything? So you obviously want to be able to see if they've got anything else to add, because most of the people say, nope, that was very thorough, which is really good. So a couple of tests that we'll often do at the end of the assessment, which I'll pass on to Caelum to explain.
So the first sort of common objective measurement might be an active stand or a NASA lean test. I know some people are familiar with this. Generally, it depends on the individual. So where I'll tend to often use this is if somebody hasn't necessarily had a diagnosis of POTS, because they might be presenting with some fatigue, or they might be presenting as someone with chronic fatigue or pain, but reporting, or they've ticked some of those boxes of orthostatic intolerance, and it's just one of those things, I guess, to make sure that we're as thorough as possible to get a concept of their orthostatic tolerance. So in the NASA lean test, generally, if you're doing it as a form or as part of the assessment, towards the end is great, because they've generally been sitting or at least still for 1 to 1.5 hours, generally up to sort of 80 minutes. Most or both of our assessments initially go. So often we'll tend to perform this measurement lying down, sometimes seated, depending on the individual, get an initial gauge of their blood pressure and heart rate, and then followed by 1 minute, 3 minutes and 5 minutes standing is how I tend to do it clinically. And you can see there it's missing a few steps on the NASA lean test, but as allied health, we can't diagnose, but we can get a really good idea as to what's happening from an orthostatic perspective, to then go on and refer on if we need to for this particular individual. Generally, though, if someone already has a diagnosis of POTS, they might be already performing this at home as part of their monitoring on a regular basis. So sometimes they'll bring in a photo of their measures, and we can just have a chat about it and see where they're at. On the next slide, we've got it's quite new, so it's the Malmo POTS symptom score. If we want to get a bit more of an idea of someone's POTS symptoms, the Malmo POTS symptom score can be really useful. One thing that I note, and I know a couple of other people have mentioned, is that it is missing a domain regarding bladder function, but they do have some really good validated sensitivity and specificity. So the sensitivity is 97% and the specificity is 98%. and the optimal cutoff of 42. And I think the mean for people with POTS, I didn't record it down here, but I do use it regularly. I think it's 78, and the mean for non-POTS in their control when they validated it was 14. So there's a gulf essentially between the two. So pretty rarely, if someone's scoring high enough on here and high enough with the NASALENA or an active standing test, then and they're not already under the care of somebody for POTS, it might be worth exploring that referral on. So I'll just pass back to Jacqui for the Baton score.
Yeah, so this is something that I always perform at the end of an assessment as well, because of the association that has been identified with POTS, and as we look at if there is this hyperelasticity in the vessels, then somebody is more prone to POTS. So this is a really great simple diagram from the Ehlers-Danlos Society in terms of how to perform the Baton scoring system. This is being expanded upon to look at including the shoulders, hips and ankles, as these are also and sometimes more so extremely hypermobile joints that are not included in the Baton scoring system. And personally, I actually also ask about shoulders, hips and ankles and look at those areas as well as performing these areas as well. So we've just got the last few slides before we jump into questions, but I know there's been a few that have been answered while we're talking. So Caelum is going to talk about what impacts the autonomic nervous system.
So I guess when we start to initially discuss this, we really want to make sure that we highlight that there are a large amount of things that can impact our autonomic nervous system. So for example, if we've got someone who, let's say someone with POTS goes shopping, they might be spending more time on their feet than what they ordinarily would. They might be standing stationary for a lot longer than what they normally would as well. They have to use some cognitive brain power, so to speak, for calculating how expensive certain items are. And then they might have some emotional load as well. Maybe the thing that they had always bought is twice the price, or it's not in stock, or it might be a positive emotional thing and it's something where the item that they want is on sale. They might socially come across, they might be quite difficult to interact with people socially and find that interaction difficult with strangers, or they might have a positive experience with someone that they've not seen for a few years. And then environmentally, they might be exposed to temperatures or lights or noises or fragrances that they're not used to. So when we're talking about the autonomic nervous system, we're not just thinking of that essential physical load or our silo of physiotherapy or exercise physiology. It's getting more of a concept of all of these things that can contribute to the autonomic nervous system. So a really good way to look at this is with a bucket analogy, which is on the next slide here. So I'm not going to talk to this too much, but just I guess, because I guess most of us have probably seen this before, we see potentially all of these stresses getting poured in at the top. There might be some unhelpful advice that they've received from healthcare or others previously, which goes back into the top. But there are also a heck of a lot of strategies that we can employ to make these people and help these people live a more functional and full life, which is what we're going to touch on a bit more next session. So if we go on to the next slide, we've got for the upcoming webinar with Claire is going to be the moderator and Luke is going to be the speaker. So Luke is an accredited practicing dietitian, and he's going to talk about the nutritional aspects of managing POTS, which is something that I'm really excited to listen to. And in future webinars, as Jacqui mentioned before, we are going to delve into some strategies physically as well in terms of exercise and movement. So a couple of additional resources. So the POTS Foundation website, the POTScast is a fantastic podcast. POTS UK and Dysautonomia International, and both Jacqui and I are happy to help if people would like some mentoring as well. And then to finish off, we've got a couple of references, and then it's time for questions. So thank you everybody for joining us for the webinar tonight, and looking forward to the questions.
Thank you very much, Caelum and Jacqui, for a fabulous presentation. I'm sure we'll all agree it was very informative. And just a reminder to all of our attendees to please use the Q&A function to submit any questions that you have. Okay, so we have a few questions already, so I'll read out the first one. When looking at improving cardiovascular fitness in this population, I understand supine, supported or seated positions are preferred, but I often find in clinical practice that their fitness doesn't always carry across to walking. And for most, building on their working tolerance is more desirable. What are your opinions on working on cardiovascular fitness in a controlled environment, such as a recumbent bicycle in air conditioning, versus walking indoors or outdoors, which is more functional and goal specific, presuming that they are functional and safe?
Yeah. Yeah, very good question, because yes, walking is functional and something that we do need to do each and every day, but it is often not very well tolerated in the early stages due to being that upright posture and that schematic that Caelum talked about with poor preload. So often, 100%, if they are at that moderate level and can be on a recumbent bike versus an upright bike, again we're looking at that downward force versus so recumbent bike legs are more coming across that horizontal, definitely indoors where it can be air conditioned, etc. Then that is a great way of building that cardiorespiratory fitness, as well as I often like to look at, can somebody have some of like the little foot pedals where they might be able to have feet elevated slightly underneath a table, and they're doing like some arm ergometer type work as well from a cardiovascular fitness point of view. If they're a lover of the swimming pool, I mean, swimming is great because we've got that hydrostatic pressure, number one, which really helps, and they're also horizontal. They don't need to be able to swim strokes. I mean, even, you know, with this population, if a lot of them are also kind of hypermobile and have a lot of neck problems or that coat hanger type pain, as silly as it may look, but snorkel and goggles are really great. And they just need to be able to do either some kicking with a kickboard or you know, just some breaststroke, or if they are a bit of a swimmer, they can do some kicking on their front or their back with a kickboard, for example. So yeah, lots of different ways to build that cardiovascular fitness without including walking initially, until we've built that lower body and that core strength to help that venous return. Caelum, I'm not sure if you've got anything else to add to that.
Yeah, probably the only thing that I would add as well is it depends on the setting that they're doing it to. So if we think back to, I know I covered it extremely quickly just now, but so for instance, people might not tolerate going to a gym real well because there might be a lot of sensory additional factors that are adding to that load of that activity. And so you might be getting someone performing some exercise pedals recumbently at home, and their heart rate may not go over 80, but then you might have the next person or that same person do those pedals at the gym, and they might be struggling to keep it less than 120. And I guess just teasing out some of those factors that might be contributing to that as well, and reasons why they may not be tolerating it, to give us some idea as to what load might be on their autonomic nervous system as a whole, and where to give us some insight into where the body might be trying to shunt that blood so that it can get the best use out of it too. And that will impact that cardiovascular function.
Great, thank you very much. Somebody else has asked the question, would you recommend the use of a heart rate chest strap during sessions?
Yeah, I think it's not essential. We don't need to, but they are very useful. We can just use a perceived exertion scale. So the Borg rating of perceived exertion, it can come in a 6 to 20 or a 0 to 10. It's easier 0 to 10. But I guess rather than getting people to pick numbers, choose the description or whatever suits them. We can also use heart rate. One consideration with heart rate, though, is what sort of medication they're on. If they're on a beta blocker or if they're on ivabradine, how is that impacting their heart rate? Because we don't want to necessarily go through a calculator that you might see in a protocol for POTS, like a Levine protocol, and calculate their heart rate. And even though it does say in that protocol about beta blockers, but ivabradine being quite new, it doesn't reference it. And so if someone's on ivabradine and you're telling them to push quite hard up to a certain heart rate, it's generally going to end pretty badly. So usually a combination of RPE and heart rate I tend to use, even if they've got a heart rate monitor.
Yeah, and that's where I like to, really look at and really gathering the data. So I will often say to a patient that I want them to write down, their movement or exercise data for at least 7 days. Because even if somebody is on a beta blocker, we'll be able to see what their heart rate is on their medication and still be able to work out that average heart rate to enable them to work within a safe zone, which we'll go into in much more detail in the upcoming webinars around exercise and movement.
Great, thank you very much. Another attendee has asked, when testing blood pressure and heart rate during the lean test, are you using a manual or automatic method?
For me, I'll tend to use a manual blood pressure because that's all I've got, and then usually coupled with a pulse oximeter. For some people, if they it's reasonably common that for some people in POTS that they might have not the best blood flow in their hands, so pulse oximeters may not work effectively. So sometimes we do have to use manual, but that's extremely rarely. For some people, if they've already got a heart rate monitor device, we can use that and a pulse oximeter as well as that device. Don't forget to make sure if you're taking blood pressure just to do it on the opposite arm as the heart rate and vice versa, just so you get an accurate measurement there too.
Great.
But I don't think it actually matters.
No,
if you've got access to an automatic machine, go for it. Yeah.
There's just what we find is, I guess, maybe a little bit of a delay with the automatic ones, but I guess it's just what you've got on hand.
Yeah, absolutely. Thank you. Okay, another attendee has asked, they've got a patient who loves Pilates and who has a goal to return to reformer-based. Do you recommend reformer or mat? And how would different positions and quick movement positions affect the ANS? Is this recommended?
I have this Jacqui here to do on a daily basis. And it's great because for people that like Pilates, it's such a great exercise to return to. But it's like, okay, let's just focus on 1 or 2 exercises at home that are mat-based first. And then you might progress up from there, try and increase that volume before we then move up with higher intensity. Again, these are things that we'll touch on in future sessions, but eventually to the point where they can graduate, so to speak, from doing their home-based activity to Pilates back in reformer, in a reformer situation. Or if you're working in a clinic with them, you might go into a quiet room and do some mat-based work and then gradually progress to reformer.
Yeah, because it is about that, the endurance level and you know, nobody wants to pay for a class they can only do 10 minutes of, and we don't want that boom and bust. I'm a huge lover of reformer Pilates for this population. And I always say to my patients is, you know, it can go either of a couple of ways, is whether they start with, you know, the upright exercises and finish with their lying down exercises, or vice versa. But we definitely do not want them doing an upright couple of exercises and then lying down and then getting back up again. It's got to be either all upright and all lying, or vice versa. We just cannot have them, you know, bobbing up and down, or they're just going to essentially contribute to a setback.
Great, thank you. Another attendee has asked, are there rough calculations for dosage of salt in this population?
So I assume Luke will probably touch on this a little bit more in his presentation, but I mean, the research goes anywhere from 8 grams up to 17 grams, I think. It's a huge amount. And I guess just talking for myself a little bit, and this is very much what the discussion around salt is you might have a lot of, and what I typically see in clinic is a lot of patients report that increasing salt troubles their gut, and they just cannot have salt without having gut issues. So sometimes we just need to work on a small amount first, and then we can gradually build up. And that's why it's important to get a gauge of where people's salt intake is, because if you know that they may not have optimal blood volume, and generally in people with POTS, you're looking at about a 13% blood volume reduction on average. If we start to push them, or even do too many things that are upright and we're not getting that optimal venous return, it can certainly start to impact function. And so, yeah, for me, I guess I've just learned over the years, and that's very much what I like to work with patients of, if they can tolerate it, working with them to know when it might be an appropriate time to stick to their usual amount, or when they might want to consider having a little bit more to assist with that blood volume.
Great, thank you. Another attendee has asked if there is any remote support for patients who may not be able to come into a clinic and to get some specific support from allied health. Is there any opportunity to access support via telehealth or other means?
Yeah, I mean, I will say Fraser Burling is an amazing man. I've known Fraser for a couple of years, and yeah, Fraser works with a couple of physiotherapists over there in New Zealand who I believe also do telehealth, very experienced in this field. Anita Crawshaw being one of those. But you know, Caelum and I do a lot of telehealth work as well, nationally and internationally, because unfortunately, nationally and internationally, there are unfortunately not enough qualified and knowledgeable people. So hence why we find with these populations as well that we can treat people very, very well from a telehealth perspective. So yeah, there's a couple of options there. Whilst I am talking, I did see, Claire, you already responded to PIP, but PIP, yeah, breathing dysfunction is something that I see in a lot of my patients, and particularly in a lot of the EDS patients. We know there is this coat hanger pain, this dysfunctional breathing pattern, you know, promoted by that adrenaline, that fight or flight mechanism. Jeannie DeBon is an amazing movement therapist in the UK, that does a lot of work in this area, and it's definitely something I teach my patients about, you know, breathing, that spatial awareness, their body awareness, and you know, that can really help to work on that autonomic nervous system as well.
Great, thank you. So our final question for this evening, one of our attendees has asked for effective communication strategies that we can teach our clients or patients to advocate themselves effectively to their GP or specialist.
Yeah, I actually, after the POTS conference, I went to a local GP here in the lobby immediately afterwards and asked her what the best way would be, because it's something that's quite difficult. We do have to be quite sensitive around how we maybe raise these sorts of issues with GPs and referrers, because we obviously want to maintain that referrer relationship. And maintain the trust that the patient has in their GP as well, because they've got rapport. But I know this particular GP said any reputable articles. So I guess the key thing that I do there is that if you've got reputable articles that are easy to digest, whether the person wants to print it out and you can explain the crux of that article to them and say, look, I've been noticing this, and my exercise physiologist or physio or whoever it may be has done this test on me, and they would like this to be looked into a bit further. And I know, as you said before, Jacqui, too, that's where for us as allied health, we have to be quite ready to communicate via phone, email, fax, whatever it might be, to make the GP or the referrer aware of what we might have found in that consultation as well. Yeah,
and that's hence the thoroughness of our assessment and how we can really talk to all of the bits and pieces. And in my time working with this population, in ways of communicating, I've often talked about, such and such presents with features of blah, 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 blah. And as Caelum said, referring to particular research, which I've often had to do for NDIS reports and things like that. So, we do that in obviously the most gentle, professional way. And we're kind of trying to lead them and their interest towards taking a bit more of an open look. And if we've done those, the blood pressure and heart rate readings and included all of the other features that fit with the diagnostic criteria, then, GPs are often pretty open to that. But I always say to my patients, I'm more than willing and open to write to their GP, and that next appointment, they're essentially rocking up with my letter, or just last week I had a GP call me whilst they were sitting with the patient, which I was more than happy for them to call me on my mobile, and the patient gave me the heads up and I was ready for that. So it's just the way we can support them.
Thank you. And Claire, did you want to add something to that as well?
Yeah, just before we sign off for the night, just on that, the POTS Foundation will be working particularly over the next couple of months to get some resources up. And one of the resources that we really want out there is some kind of a information sheet that patients and allied health can use as a tool for patients to take to doctors, basically introducing what POTS is and what that particular person has in terms of symptoms of POTS, just to give GPs some direction. They have very little time, so my advice would be that whatever you write or say to them, that it's brief and to the point, and it's something that they can really digest in a small amount of time, because they have such limited time to be able to fully assess patients. So they're usually relatively grateful for a well-structured, to the point assessment with some leads for them as to what might be beneficial for the patient, without telling them how to treat them, but perhaps how to, further manage that.
Yeah. Thank you, Claire. Sadly, that is all we have time for this evening. So I would like to say a huge thank you to our presenters this evening, to Caelum and Jacqui. Thank you for a very fabulous and informative presentation. I'd like to thank all of our webinar attendees and hope that you have got a lot out of this evening. And please do keep an eye out on your emails for an evaluation form, which will guide us in planning these future webinars. And just a reminder that our next webinar will be held on the 23rd of January and that can be registered for via Humanitics. Thank you again. Have a lovely Christmas, everyone, and we look forward to a productive 2023. Take care.
Thanks a lot, everyone.
Thank
Bye.
you.
Thank you.
Bye.